Good afternoon, everybody. I'd like to call the meeting to order. Thanks my members for being so prompt. We actually are not having to wait on a quorum today, so thank you very much. So I will call this meeting to order. And our first business of the day is to hear our colleague from across the hall, Senator Goggins, his school-based health care bill, Senate Bill 183. Senator Goggins. Just right there at the podium.
Thank you. Thank
unless
you,
you'd rather sit, Senator.
I'm good here.
I'll be nice to the other, on the other side, the upper house.
Madam Chair, it is my privilege today to present to you and to your committee Senate Bill 183. And this bill just revises Code Section 20-2-771.2 relating to school health nurse programs. And it's a very simple bill, lines 13 and 14. And it states, and may include consultation with off-site health care professionals through appropriate protocols and contracts. And basically what this is for is that you have school systems now that are using telemedicine. And we were asked just to pass this legislation to take care of any legal issues that they may have that may arise. And this will allow them to use telemedicine. As you know, Madam Chair, how wonderful this program is now throughout Georgia, and how what a benefit it is. And that's just the change it brings. For each one, you should have a little bullet point of 4 positive things of why we need this. And I will yield for questions.
From the committee. Okay. Representative Purcell?
I'd just like to say that telemedicine is really a popular thing across the state, particularly with the medical community. So I'm glad to see that you mentioned that, because as I read through the bill, I saw nothing mentioned about telemedicine and the telecommunication. So thank you.
Thank you.
Okay, and that has been a question that I've had asked, Senator, that it doesn't really specify. Does legal counsel think that just saying that it's off-site health care, for consultations off-site is specific enough?
Well, it's written more broadly, so it could include things like email consultation or telephone consultation or something like that. It still has to be in accordance with protocols and contracts, though, so it would be restricted that way. But it would be, in my reading, it would be broader than
Then, okay.
But telemedicine was the impetus for this.
Okay. So you're comfortable with the fact that
Yes.
it is broader. Yes. Representative Byrd.
Thank you, Senator. I just want to be clear about this. You are asking that school health nurses have the ability to do telemedicine and any other things that they need to do.
The protocol would be set up by the school board that would allow them. And you have, obviously you know about telemedicine and how it works and so forth. And it would just be the school nurse would be the person there with the telemedicine. And if they were using an emergency room or if they were using a primary care physician, that nurse would facilitate that appointment while that child's at school instead of having to go to the emergency room.
Thank you.
Okay. Is that it, Representative Byrd? Yeah. Does that take care of it? Okay, Representative Pack.
Senator Goggins, one question. I know the added language says and may include consultation. Was there a purpose behind that, or could it say or? So in other words, you don't have the option to consult with someone off-site unless you have a nurse present?
I'm not sure I understand your question.
Because the language reads that if you have a established policies and procedure regarding school health nurse program, that program requires a staffing by a licensed healthcare professionals and may include, so in order for someone to be able to consult someone off-site with a healthcare professional through protocols and contract, you still have to have the nurse at the location.
Yes.
Okay.
Yes, you still have to have the nurse.
That's right. Okay, thank you, Betsy. As always, we have Betsy, our legal counsel, with us, and Betsy sitting over there, shaking her head.
Yes.
And Representative Back, good question. Are there other questions from the committee? Well, Representative Chokas.
Madam Chair, I'd like to recommend that we give this the do pass recommendation from the committee.
Got a due pass and a second. Is there any further discussion? No, seeing no further discussion, call for a vote. Everybody in the favor of the Senate Bill 183, say aye. Anyone opposed, no. I think the ayes have it. Thank you very much, Senator.
Thank you, Madam Chair, and thank you to the committee.
Before we begin the discussion of the next bill, which is Representative Oliver's bill, House Bill 23. I know Representative Oliver has people that want to speak, and she'll introduce those people. Is there anybody else in the audience that wants to sign up to speak? There's the pad is on the corner here. Okay. If you will just pass that around, or there we go. Thank you. Be sure to sign up. Let me send Justin. Can you go back by the door and hold that when Mrs. Joyner is finished with it? And then if anybody else wants to sign up to speak, you can step back to the back, and Justin and I will have the sign-in sheet for a few minutes. Representative Oliver, thank you very much for coming. And are you ready?
Yes, ma'am.
Okay, here we go. House Bill 23, the Foster Children's Psychotropic Medication Monitoring Act. Go ahead.
Thank you, Madam Chairman, very much for this opportunity to have a discussion about House Bill 23 and a very difficult health care issue for Georgia. Georgia has the obligation, whenever it takes a child into foster care, which it does probably 10 to 20,000 different children a year, and probably over 8,000 children today in foster care, has an obligation to provide medical care. And specifically, in the Fostering Connection to Success and Increasing Adoption statute, federal statute, which pays for most of the foster care funding that we provide in Georgia, it was required that states, all states, adopt some mechanism, some way of providing oversight for particularly psychotropic medical prescriptions for children. It's a national issue that children are over-medicated in foster care. This is, a lot of folks are doing research on that. It's dramatically higher than the Medicaid population and higher than the general health population, and some of that is understandable. Children have been traumatized, they've been injured, and they're in a wide variety of very assaultive type arrangements. So mental health issues are obviously going to run to the top. From this federal statute, the Georgia Supreme Court, and Justice Harris Hines is here, will talk about his role in collaboration with Department of Family and Children's Services, undertake a way to look at issues of foster care that were most in trouble in the system. And particularly one of the issues that they might be in trouble is health care, and particularly mental health services. He and Michelle Barkley will talk about the Cold Case Project, which examined this issue in detail. And following their initial reports that they'll detail for you about this issue, I filed a Freedom of Information Act request with the Department of Medical Assistance and learned that $7.8 million annually is expended for 23,000 different foster care children for psychotropic drugs. And we define those kind of a heavy-duty set of drugs. And a good percentage, represented over a third of the children in foster care, which was above the national average. And the cost reports also showed that many of these children were on multiple psychotropic drugs in a way that probably was not represent medical care good. I introduced House Bill 23, and the good news here, and this is what I really wanted to share with the committee, is that Casey Foundation came forward over a year ago and funded a pilot project to do an analysis of this particular issue. How could Georgia carry out its duty under the federal law to provide this oversight, and what was a true, accurate analysis of this issue to the extent it may be a problem, and I think it is a problem for us to resolve. So you'll hear today from the Casey Foundation executive who generously funded this project, and then in your materials that have been handed out to you is a report, executive summary of the report, and Dr. Brent Wilson, who is the psychiatrist who's done most of the work, much of the independent work on this analysis funded by Casey, with the Barton Child Law and Policy Clinic will give you his recommendations for one way to do oversight that meets the standards of the American Academy of Child and Adolescent Psychiatry. So that's a lot of stuff to cover, Madam Chair, but I think it's a good, positive discussion about the extent to which Georgia has worked in a collaborative way to solve what is a difficult, I think a difficult, medical issue to resolve. First, if I may, Madam Chairman, I'm going to ask Mason McFall and Giovanni Bazan to come forward and sit right here. These two gentlemen can tell you their personal experience with psychotropic drugs in the foster care system.
Ready to go. Thank you very much, Representative Oliver, for bringing this issue forward. As you know, our foster children have a special place in my heart, and in our former First Lady's heart too. And I want to thank both of you young gentlemen for coming forward. I know it can't always be easy to come before a committee of legislators and tell your personal story. So let me just, before you start, say thank you very much for that. And you can decide between yourself who wants to go first. Is it on?
Good afternoon, ladies and gentlemen. My name is Giovanni Bazan. I'm 21 years old. I went into the foster care system when I was 11 months old, and I went into the juvenile justice system when I was 12 years old. I was adjudicated from the system at 19 after having been in the system for the majority of my life, obviously since I'm 21. I currently work for Georgia Empowerment as a project coordinator for Empowerment's Just Georgia initiative, where we worked as part of the coalition member for the Just Georgia project to revise the Children's Code, which is a complete overhaul of the 40-year-old set of laws that deals with children and their families in case of abuse, neglect, and court intervention. Basically, what I'm here today is to discuss or to inform you guys about some of the experiences that I experienced with psychotropic medications, having gone through the foster care system, as well as the juvenile justice system, and how that pertains to House Bill 23. And prior to me speaking, I would like to say that in reference to House Bill 23, it goes to the extent of excluding the Department of Juvenile Justice from being a part of this Psychotropic Monitoring Act. I find this extremely disconcerting, seeing as the atrocities committed within the Department of Juvenile Justice to control the youth in the system by forcing them to take psychotropic medications is just tragic, to say the least. While I was in the juvenile justice system, I was told myself that if I did not take the medications that were prescribed to me for antidepressants or for depression, for reactive detachment disorder, for oppositional defiance, and so forth and so on, all these negative stigmas that were attached to my name just because of the circumstances I was going to. Obviously, as a child, obviously as a youth, we have a bit of rebellious spirit, to say the least. I'm sure we can all agree to that and attest to that. But that doesn't mean that we're mentally ill. And that's the stigma that is labeled to the majority of the foster youth and juvenile justice youth. Like I said, I was told that if I did not take the medication that was prescribed to me, then I would not get off probation. I would not be allowed to basically earn my freedom, and so it was a way to chemically control me. Also, while I was in the care of my foster parents, growing up in the foster care system through my childhood and youth was an extremely abusive situation. It was abuse from physical, sexual, emotional, all aspects of abuse that I experienced, as well as chemically with the medications, because my foster parents would use it in a way to control me. They would say, okay, well, we don't like the way you're acting. We're going to tell your psychiatrist that you're just belligerent, that you're out of control, and we're going to basically make them up your dosage. And it would be to the point where I would be sedated, as my friend Mason is going to explain, much in a similar situation. My entire persona was completely altered and changed. Kids at school would tell me that I wasn't acting like my normal self, and it would vacillate so frequently. My persona would vacillate so frequently that people felt that I was in fact schizophrenic because my behavior would change so often. It was at one particular incident, and I would like to say that it's extremely dangerous using psychotropic medications with foster children, unregulated, and without prior knowledge of their medical history. such as the case for Gabrielle Myers, who was 7 years old, committed suicide after being prescribed multiple psychotropic medications that were not approved for people at such a young age. In my specific circumstance, when I was 16 years old, a doctor prescribed me heavy antidepressants as well as sleep medication. Antidepressants to pick my mood up and sleep medication to sedate me. At the time when they gave me this medicine, I went back to the group home and the group home staff administered it to me. The dosage was so high for the antidepressant that my body convulsed and reacted to it negatively. I vomited the contents of my stomach, but because the sleeping medication was also so high, because the side effect of the antidepressant kept me from sleeping, that I was unable to wake up, and I unconsciously lay suffocating in my bed at the group home, unable to breathe and near death. Had it not been by sheer luck or divine intervention that the staff member happened to walk by and glance in my room to see me blue, suffocating, almost to the point of death, and was able to turn me over and eject the vomit that was lodged in my throat, suffocating me, then I wouldn't be here today. And that is I just want to express that to show that it is direly important. And the foster children, our commitment to foster them with care within the foster care system is absolutely imperative, that we pass this bill to at least take this first step in providing oversight for the children and youth in the foster care system.
Thank you.
Thank you again for having us. My name is Mason McFalls, and I'm 24 years old. I work for Morgan Stanley. I was in the foster care system from the age of 7 till 21 whenever I was emancipated. And after spending that time, I moved about 10 different times, somewhere around there throughout the state of Georgia. So while you're speaking more from what he's seen or happened to him, I'm speaking more from a perspective of what I've seen throughout the different foster homes that I've been a part of, as well as group homes. And in many different situations, I've seen it, as Sir Giovanni mentioned, I mean, almost every foster youth I've ever met has been medicated to some degree. And whether or not that's deserving, I'm not here to attest to that. I'm just saying what I've seen, the effects of what's happened. I've seen kids literally shaking from being so wound up on the medication they were on because they were sad or depressed before, to the opposite effect of where they were sad and depressed because of the medication that they were taking throughout the homes that I went. I've also firsthand experience on several occasions foster parents prepping the youth to go see the psychiatrist, saying, okay, be sure to tell him this or be sure to tell him this, so that way the foster youth would be prescribed certain medication based upon what the psychiatrist thought to be what the child was experiencing, but wasn't the case. The closest I've had the experience to was my brother and I both saw a psychiatrist, and I actually wasn't prescribed anything, but he was prescribed. Beforehand, he was just really rambunctious, like excited about life kind of guy, I guess. And then afterwards, he became severely depressed, would hardly ever talk to anybody, stayed closed up in his room. I mean, he was on several different medications for this, and then he'd get medications to counteract what the side effects were of the medications he was given. And it got to the point where he kept begging to be taken off the medication, kept begging to be taken off, and he wasn't, until one day he threatened to commit suicide, and then they decided better start taking him off. And also you got to know that they can't even be just cold turkey stop taking this medication. It has to be cycled off. That's the degree that it's changing their personality. And I do believe that there needs to be more oversight, but more than that, I think that we need psychiatrists and whoever's checking into it needs to look at the intent behind the medication. Is it used just to calm down an excited kid, or does it, and in addition to that, I think they need to figure out whether or not it's something that the child wants. Does he want to be calmed down? Is he feeling sad? Does he admit to it? Is that the best method? Are there other methods that we could go other than prescribing this medication? I think that's something that definitely needs to take a closer look.
Okay, are both of you willing to take a few questions from it's your choice?
Sure.
Okay. Let me start it off by saying that I believe one of the responsibilities of government is taking care of those who, no fault of their own, cannot take care of themselves. And I would certainly apologize to you for where our system failed. Because both of you are talking about things that happened in the state of Georgia, right? So first of all, let me just say I'm sorry for the things that happened. I'm certainly proud of both of you. You seem to have found direction in your life and have overcome the obstacles. So I'm very proud for that. But it's a complicated process, and what I'm hearing, no foster home should sexual abuse or physical abuse have been allowed. And Giovanni, am I hearing that occurred and happened to you? Is that correct? How were the foster homes that you were in? The different ones, Mason?
The different foster homes that I was in, it varied because the reasons for them becoming foster parents obviously varies. I've lived with families of different ethnicities in rural areas and urban areas of socioeconomic wide variety of differences. And with that also came a lot of differences according to how they treated me, and I actually was abused in one of the foster homes that I was placed in as well.
Was this ever reported to the social worker? Am I correct? Representative Oliver is supposed to be a social worker assigned to each of you as foster children. Were these incidents reported?
Yeah, well, see, the trickiness of the scenario is that the foster parents who were abusing me obviously are not going to self-report themselves.
No.
And at the time when I was I was so young that developmentally I didn't maintain or obtain the capacity to be able to articulate exactly what was transpiring. So what would happen is I would go before these social workers, I would go before the psychiatrists, psychologists, all these people I didn't even know who they were, and was expected to divulge every intimate detail of what was transpiring. And when I would explain it, my foster parents would basically come behind me and say, he's a compulsive liar, he's a manipulator, he's the deceiver, he's doing this to obtain attention. None of this actually transpired. And so it completely negated everything that I was saying, although it was all factual and all completely true.
And Mason, why were you moved so many times? I'm trying to get at, not at your fault, but if you were moved 10 times, were there reasons given to you why your foster home was changed 10 times?
I never really understood why we moved between group homes a lot. Some of the scenarios happened because people that they were trying to set us with to become foster parents decided, a couple months into it, hey, I don't want to do this anymore, kind of deal. And so that accredited a couple of the changes. But I also wanted to say what Giovanni was talking about. Whenever you're young and you're told whenever you're not with your family and you're being abused for a second time, at that point you start to think, A, this probably happens everywhere. And so there's really no point to tell anybody. Or then you start to think as well that, B, that if the system doesn't take you out that day, which I think is a big fault, that if they find out you're being abused, we're going to do an investigation. What happens to the kid after the parents know there's an investigation happening? Think about how frightening that is.
You have to go home.
Thank you. Are there questions from other committee members? Representative Byrd.
I do. Thank you. My parents had foster children, so I can understand. Do you go through an evaluation when you go to the Department of Human Services or wherever they take you as a foster child, and are you evaluated at that point by a psychiatrist to make that determination to put you on drugs?
In my situation, I was, but
In my situation, every foster home that I went to, I would have to go see, that foster home would take me to a different psychiatrist. And what would happen is because, which HB 23 I believe touches on, but what would happen is because they weren't aware of my previous medical history, then that psychiatrist, I may be displaying a certain, I may be consistent with a certain type of behavior, but each psychiatrist would make a different ruling. They might give me a different dosage of medication, or they might give me a different prescription altogether. So that also played a big role in how that affected my behavior and the side effects and how I responded to the medication, because it was so many at a different time. And the same, I know this isn't the topic at hand, but the same was the case for juvenile justice. Every time I went to a different facility, then I would go see a different psychiatrist that was actually in that facility, and they would prescribe me a different medication, even if I was only staying there for a week or 3 weeks. And then when I got out, then I would have to go see another psychiatrist who would give me a different medication status. So, it vacillated frequently throughout our experiences.
So a follow-up, please.
Yes.
So do they send you automatically to a psychiatrist, or just when you were misbehaving or causing problems?
from what I recall. And granted, that it goes all the way back to when I was very young, so it's hard to know what was supposed to happen and what actually happened. But every time I went to somewhere new, I was sent to some place to get an evaluation. Whether that was a psychiatrist or a psychologist or a therapist, it was a numerous amount of people, so it's hard to say exactly, but
Thank you.
Okay, there's no other questions, so I want to thank both of you very much once again for being willing and coming to talk to us. And really appreciate your input. Thank you.
thank you.
I'd like to ask Justice Harris Hines with the Georgia Supreme Court and Michelle Barkley with the Commission on Justice for Children to come forward and explain their work in this area.
I will say that Justice Hines is one of Cobb County's finest, and it's nice to see you, Justice Hines. Thank you for coming.
Madam Chair and members of the committee, thank you for allowing us to have this time to talk to you just briefly today. And I would introduce Ms. Michelle Barkley, who is the Director of Justice for Children Committee, and I am the Chair of that committee. And it's very self-serving, but I don't know of any committee in the state I think has done more for the help of children in the state than this committee.
Justice Hines, I'm sorry to interrupt. Will you pull the mic over where it picks up your voice, or move your seat over, whichever?
And we're delighted to have Ms. Barkley as our director. She, like you, Madam Chair, has a health science background and is a nurse as well as being an attorney. And I think I try to talk to a jury as an attorney or as a judge, try to tell how this matter came before you, how it's being brought before you. And it came this way. When I was on the bench in Cobb County, periodically we would have just what we refer to as a peremptory calendar or a status calendar. And that is to say, all the cases assigned to a judge to make sure they weren't languishing, you would have your clerk prepare a calendar, and you would have a day or maybe 2 days you would call those cases to see the status of those cases. As we began to hear about some difficulties in the cases in some of our juvenile courts, no fault of anybody, we found a group called the Cold Case Fellows. And this was a group of attorneys who had expertise in child welfare matters. We had this funded, and to tell you how I think our committee has worked well, we've been very successful through the efforts of Ms. Michelle Barkley of bringing in what I call private monies for this. And one of the ways we got the Cold Case Project funded was Mr. Page Wally, who will maybe speak to you in just a few moments, Dr. Wally, who is with the Casey Family Programs, funded a study. We've been fortunate in having people like Dr. Wally, who is himself a former head of the DFACS in Alabama. He's a former director of that. He was a 5-term legislator in Tennessee and also has a PhD in psychology. So he understands these matters pretty well, both from the executive branch, the branch of the legislative branch, and also from that psychological background. So we were able to get a grant through his good works. And they went out into certain of the juvenile courts and looked at cases that had some age on them and languishing. And what we found was that in a large percentage of these cases, for children who had been in foster care for an extended period of time, it appeared that over-medication was somewhat of a common thread that was weaving its way through these cases. So that's how the program came to be and how we spoke, certainly with Representative Oliver and others about this. But that is how it came to be, and that is how we first really picked up on the problem through the Justice for Children Committee, which is a committee of the Supreme Court of our state. And with that, I'll let Ms. Barkley tell you that which she would like to tell you about it. But again, I would just like to thank you very much, Madam Chair and members of the committee, for being able to speak to you about this situation, and not to cast stones or anything, but simply to improve the lives of Georgia's children.
Good afternoon, everyone. And again, I want to also thank you for taking on this issue. I'm going to tell you just very briefly about the Cold Case Project, and I have a report here, which I'm sure you have plenty of things to read. But I wanted to just brief you that this is a joint judicial branch, executive branch project. We've been working on this for 3 years. Casey Family Programs is also a partner and also a funder for us. What this project does is it takes a look at the hardest cases within the DFACS system. This is done by DFACS sharing their data with the courts. And with that data together, we look at, through a predictive model, what cases appear to be stuck in foster care. And we've labeled them the cold cases just because we wanted to have a name that everybody understood. The last 3 years we've been looking at this, we've found about 300, 400 children at the time. Hopefully this is the kind of program that would find a Mason or a Jovian that a child would not go up to foster care anymore. Once we identify a child like this, we bring together a team of people to review the case to make sure that everything that should be done has been done. And we also brainstorm solutions, and a lot of people make recommendations about what else could be done for this child. Over 250 cases were reviewed last year by this joint team of experts, which includes experienced child welfare lawyers, as we talked about. We call them the Cold Case Fellows. They get to have a Supreme Court title on their resume, and they get paid a pretty low hourly wage, but they'll do it for us for that. We also have very experienced social workers, and we have a psychiatrist on our team. And starting in 2009, as Justice Hines already said, we started seeing a pattern emerge of the children who were fitting this category of cold case. They often had ongoing or profound trauma. That makes sense. That's why they're in our foster care system. They were likely to have a host of mental health diagnoses, more likely to be in institutional type care, and more likely to be on multiple psychotropic medications. A few of the children were interviewed from our team, and some of those children could not stay awake during the interview, which alarmed all of us. DFACS immediately through this project recognized the need for independent oversight, especially of these particular children, and they have been partnering, which they're going to tell you about next, with Casey to come up with some ways to innovate government and do a better job to take care of the children in this category. And I'm going to turn over to them because I want you to hear about solutions.
Thank you very much. Did I understand you that you are now, this is an ongoing project.
Yes.
You are reviewing all of these cases and trying to intervene now?
We triage things that we think need to be reviewed, yes.
Are we catching up so that we're just not going back for children that have been there a long time that are there for shorter periods of time?
Yeah, it's getting better, but we still find cases of kids that have been in foster care a very long time for many, many reasons, 6, 7 years. Hopefully no more 11 months. I've not seen a case like that in the last 3 years.
Okay, so we are sort of...
Jovian was 11 months. He came in 11 months and left it at 18, which is terrible. We still are seeing 6, 7 years for all kinds of reasons. Sometimes it'll be an adoption that was started, but it failed, and they came back in the system. They're complex cases.
I would like to say to the audience, and since this is going out of the internet, I think one of the biggest and best things that's happened is the new commissioner, Mr. Reese. I don't think Mr. Reese wanted to go there when he was moved from one department to the other. And I said to him it seemed like punishment because the DFACS problem was so great. But if anybody can try to help and get us get things straight for the state, I truly believe that it will be Mr. Reese. I've never met someone as caring as he is, who knows how the system works, but is also very smart. And I really think that when the governor moved him, even though it gave him a more difficult job, that it was a very positive step in the right direction. So at least I think that we are trying to make some changes that will bring about major differences in the lives of our foster children. Thank you very much, and thank you, Judge Hines.
Thank you, Madam Chair.
For the committee's understanding of this issue of permanency, federal law has for a long time, over a dozen years, said that if a child is in foster care for anywhere between more than 15 to 22 months, that the state is obligated to move for a termination of parental rights and a permanent plan. And obviously children that are spending their entire life in foster care is in violation of that particular standard. And that's one of the corrections that is being made in the system now, so that the time in foster care before a permanent placement is shortened. Paige Wiley, a former member of the Tennessee legislature, will join us at this time from Casey Family, and Melissa Carter, who is director of the Barton Child Law and Policy Center, will discuss with you the the medication monitoring project that Casey has funded and the recommendations that they are making to the state of Georgia for oversight based on the American Academy for Child and Psychiatrist group.
Welcome. Anybody from Tennessee has to be a good person. I hope we can say go Vols. I get in a little trouble with that around here when I wear orange, and it's red and black territory, but it's a pretty good state.
Madam Chair and members of the committee, thank you very much. And I must confess that Justice Hines and I have been checking our iPhones to see what recruiting does look like today for the respective teams for whom we cheer. I happen to live in Auburn, so my wife is here with me, who is an Auburn graduate, so we have certain divided loyalties. But thank you for allowing me to be here. As Justice Hines was kind enough to mention, I am a former 5-term legislator from Tennessee, a clinical psychologist who spent many years in community mental health, had the privilege of being commissioner over the Tennessee and Alabama systems that are the equivalent of DHS. And so this is a very important and personal matter to us at Casey Family Programs as well. I'll take just a moment of personal privilege, if I might, to say my mother is a Georgian, and I got my master's and PhD at the University of Georgia. So you can see I have divided loyalties everywhere when it comes to SEC sports. Let me thank Justice Hines and the Georgia Supreme Court, the Justice for Children Committee, and Michelle Barkley, as well as Emory University, the Barton Law Clinic for Law and Policy, and DHS and DFACS for the privilege of being able to partner with them and under the guidance of the legislature, let me say. And I'm very pleased that you all had a substantial role in directing attention to this matter and how important that has been for Casey Family Programs to be a partner in this evaluation. Casey Family Programs is the nation's largest private operating foundation with a $2 billion endowment that came from United Parcel Service, the Casey family, that sole purpose, sole mission is to provide for safety, permanency, and well-being for children and look at opportunities to make sure that foster care services that are provided for the least amount of time necessary, and that permanency for children is what is paramount. The state of Georgia, the state of Tennessee, the state of Alabama, every state makes a poor parent. Families make good parents. And the degree to which we can support and provide for the strengthening of families, that will best serve for the safety and permanency and well-being of children. With that said, we have been very dedicated to working with the partners on this project around psychotropic medication utilization management. And it is a national challenge. You'll see articles about it in newspaper clippings every morning. I forwarded one just this week to our partners on the struggles that the Nebraska legislature is having right now in wrestling with this same matter. But what has been done in this initial step in which we have worked alongside of the partners is very encouraging, because permanency is the outcome to which we're investing probably about $600,000 per year with DFACS in doing this work on safety and permanency for children with the courts, as you heard on the cold case project. And my superiors look at outcomes. Georgia has done a remarkable job the last 7 years in developing permanent placements that are safe for children. Over 13,000 children were in foster care in 2005 in Georgia. That number decreased by the end of 2009 and 10 to about 7,200. About a 48% decrease. Now it has begun to creep back up again, about an 8% increase in this past calendar year. And there are issues that are challenging, and we are very privileged to be able to work with DFACS and others to look at what those are so we can come along and provide our expertise, our resources, our getting in harness with the department to find solutions. Anything that impedes permanency for children in forever homes, we want to be a part of trying to help address. And so with Justice Hines, Michelle Barkley, and who you will now hear, Melissa Carter, from the Barton Child Law and Policy Center, we're committed for the long term to working with Georgia to making sure that safety, permanency, and well-being are paramount, and if this is going to be an impediment, we're committed to making sure that we come alongside and are part of the solution.
Well, good afternoon. Let me add my gratitude to the choir of others for your attention and the attention you'll bring within the state to these issues. By way of reintroduction, my name is Melissa Carter. I am the director of the Barton Child Law and Policy Center, which is an interdisciplinary child law and advocacy center at Emory University. By way of helping to connect some of these perhaps disparate programmatic pieces, and also to let you know that I had served previously as the state's child advocate, and in that role came to become aware of these issues in a much more specific and concrete way through the kind of anecdotes that you heard, the life experiences of the youth that we're serving in this state, like those represented in the stories that Giovanni and Mason shared courageously with you. And through that work, and as the state continued down its strategic and deliberate efforts to safely reduce the state's foster care population, we came across and have now sort of a more difficult population of youth in foster care. And those more difficult kids in profile are the ones who are older, who have stayed longer in care, who tend to have these complex histories of trauma and of mental and emotional disorders. And those are the kids as well that tie into the Cold Case Project as described by Justice Hines and Michelle Barkley. And so how did we get to where we were? We sort of took that general concern for our kids and tried to design a pilot project led now by the Barton Center for the past year in collaboration with many partners who you've heard from, as well as in close partnership, you should know, with the Department of Human Services, the Department of Community Health, our Medicaid agency, and the Department of Behavioral Health. We have had great cooperation on these issues, and I think a sustained and shared commitment to improvement in these areas, which I'd like to make sure that you all are aware of.
System?
Oh, I'm sorry.
No, but I mean
Absolutely.
ours on the state level.
At which we certainly work closely with the juvenile courts, with the Supreme Court through the Committee on Justice for Children. Yes, the judiciary is well represented in these issues.
But no, I'm talking about once they are in our system, what's the DOJ?
Oh, Department of Juvenile Justice.
Right.
Right. So Department of Juvenile Justice, as we designed this project, we did not include the Department of Juvenile Justice, mostly as a practical matter, because the way that they are structurally organized, they had a medical director, they have psychiatrists in each of their facilities, and so it provides a different landscape for addressing the issues. It was not at all to suggest that they don't have similar impact on the children they serve, as you heard. And so let me talk to you, take this opportunity to talk to you specifically about the psychotropic medication monitoring project that we've led for the past year. As you've heard, the expanded use of psychotropic medications to treat emotional and behavioral problems of children presents both quality of care concerns and budgetary concerns. Utilization rates are highest among children in foster care, on the order of 3 to 4 times the rate of comparable Medicaid populations of youth, primarily because the illness severity, the mental health needs of this population are greater, both because of the trauma of the original abuse and neglect, as well as the experience of continual and repeated disruptions of attachments and routine. And you heard from our youth speakers about how that trauma may manifest in behaviors that present as symptomatic of behavioral and emotional health disorders. Likewise, there are unique systemic problems that create greater risk for children in foster care and their exposure to being over-medicated or improperly medicated. The kinds of fracture I'm talking about tend to happen as children change placements, they change providers, again, as you've heard, and medical records are not well maintained and they don't tend to follow the children. And so when children do present with those symptoms of behavioral or emotional disorders to a treatment provider, there isn't all of that context and medical history that accompanies them. And so we're left with a limited framework within which to work and make treatment recommendations. One danger that you'll find repeatedly throughout the literature is also the fact that children in foster care have higher rates of polypharmacy, the use of combination medications. and the efficacy and safety of those in combination are not well understood and not well proven, particularly for use with youth. And again, related to that is, as you heard from our youth speakers, the occasion to use these substances for the convenience of a foster care provider or to manage in this fractured system as a way to manage behaviors. And that sometimes when you have so much fracture and so much disruption in the system itself, that those expedient solutions, like a medication treatment, tend to become the most popular and easy to use. And so we've had the privilege to partner with Casey Family Programs, building on the work of the Cold Case Project that you heard, to examine this state's landscape of oversight as it currently exists and to make recommendations for future direction for improvement. As you heard, the federal government, Congress has passed recently in 2008 and as amended in 2009, congressional mandates to the states to pay specific attention in the child welfare system to the use of psychotropic medications and to put forward protocols for coordinated health care and again the administration of these substances particularly. And so we would hope that this project and its design also helps inform the states and facilitate the state's ability to do that and to put Georgia in a position of leadership in the nation. Our immediate goal was, of course, to address the questions of quality and cost that we've talked about and that Representative Oliver addressed in her opening comments, while facilitating the state's compliance with the federal mandates. To that end, we've spent a year conducting extensive legal research, examining closely the medical literature on the safety and efficacy, of these substances. And again, on the legal side, looking at issues of consent and assent and how to accommodate the youth voice so that these youth who are treated with these medications are well advised of what they're for, that we have engagement in treatment that will help sustain the best outcomes and ensure the best outcomes for youth. We've conducted close review and evaluation of the existing policies, DFACS policies. The Department of Behavioral Health has a set of medication utilization parameters that guide prescribing practices. We've conducted close evaluation of those. Conducted training with DFACS workers at all levels, as well as a cross-section of juvenile court stakeholders and foster parents, for example, to promote awareness and a greater vocabulary around these issues so that those providers at all levels, we can all be engaging in advocacy for the youth who we have access to. And also we've conducted, through a contract with a child psychiatrist, case reviews of a select number of foster care cases, again derivative of the Cold Case Project that you heard about. And I believe you'll hear from Dr. Brent Wilson about his specific findings from those case reviews. Our recommendations, which have been presented to you through the executive summary, I think that's been provided, are intended to help the state architect a balanced approach to oversight, the oversight that's now required by the federal government, that's warranted as a sort of moral and legal consideration on behalf of, out of respect for the youth and their experiences so far. But to make sure that that approach, again, is balanced and that it recognizes the value of medications as a treatment option, because they certainly have a valuable role, as well as the need to build additional capacity, service capacity for alternatives, and safeguards to make sure that we achieve the best results for the youth in our foster care system. Those recommendations are modeled against the framework that's provided by the American Academy of Child and Adolescent Psychiatry, which address, again, specific elements of consent, oversight, expert consultation to the field, and information sharing and agency coordination around these efforts. As you've heard, as you understand, this is a complex issue involving a number of our state agencies, and so it really does require a multi-agency, multiple level of system kind of response.
Wilson reviewed intensively the files of 93 of the 250 approximately cold case files, and has been the architect of much of the data on this, and he would like that as a final witness. Madam Chair, he would like to come forward and talk about specific contents of the 93 files that he has reviewed, and I've lost sight of him.
Well, that's fine, Representative Oliver, but let me, and thank you to the presenters, and please convey to the KC Foundation Board our appreciations for their involvement in our state. With money being extremely tight, a private public partnership is certainly advantageous, and their interest in the welfare of children is very much appreciated. So hope you will tell them that.
Thank you, Madam Chair, members of the committee. I will relay that. My great pleasure.
Okay, thank you. Do I have, it's fine. Okay, thank you. Dr. Wilson.
Well, I appreciate the committee's time and the consideration of this bill. Also Representative Oliver's request for me to speak, and also to Casey Family Programs, to the Barton Center, and to DFACS for being a part of this project. There's a lot of previous congressional testimony at the federal level and other national studies that clearly document the concerning issue. Quite simply, as you've already heard today from the foster children in the audience, that they are more likely than any of their Medicaid recipients or the general population to receive psychotropic medications. Foster children in Georgia, in fact, utilize these medications at rates that exceed the national averages in other studies. My clinical time is spent with publicly funded children and uninsured children, and reviewing these cold cases, as you had them described, represent a subset of children that are on medication profiles that I hadn't seen in that number throughout my training. And I think I'm here today to present to you some of the findings from the 93 cases that I reviewed.
Dr. Wilson, you are a child psychiatrist?
Yes, ma'am.
And where do you, so the committee will know, where do you work, where do you go to school? Just give us a little background.
Sure. I hail from Maryland, went to Davidson undergrad, Penn State for med school, and wound up in Georgia for residency at Emory.
Oh,
I did my adult and child training at Emory. I've been here about 7 years.
And you do
my clinical work is now with one of the community service boards in the state. They serve uninsured individuals, adults, and children with mental health and addictive disease. I work at one called Viewpoint Health, which was previously known as GRN, directing their child crisis stabilization unit.
Okay, thank you.
In the cases I reviewed as part of this pilot project, I did some in-depth reviews which included face-to-face evaluation of children, and others that included a comprehensive review of the medical records. It also included talking to medical providers, their therapists, case managers, or other community advocates, a guardian ad litem or a CASA. The cold cases definitely represent a unique set of children because of their length in time in care and their accompanying mental health needs. Frequent moves that you heard about before from Giovanni and Mason, that leads to the fragmentation in care that you heard several people discuss as well. Our National Academy, and I think colleagues of mine that you may hear from today, would argue that these are some of the most difficult children to treat, and I would agree with that. However, the 93 cases I reviewed still had some concerning medication combinations that I'd comment on. The most consistent findings through our review process were, number one, high rates of polypharmacy, which you heard Melissa talk about earlier, the use of multiple medications at the same time. High doses of medication, so seeing medications used at the maximum dose for adults, or two medications both used at the maximum dose or above maximum doses. Some non-evidence-based prescribing practices, and lack of appropriate oversight. Related to the polypharmacy issue, it wasn't uncommon to see children on 3, 4, or 5 medications. Some kids that I reviewed earlier on 8 or more medications. It was particularly concerning the side effects that you heard mentioned earlier of sedation or other movement-related side effects that required additional side effect medications. Tying into the non-evidence-based prescribing practices, there's not much evidence to suggest using 2 or 3 or more medications, which if you're familiar with the GAO study that recently came out, that's pretty well documented. So once you get in the realm of 4 or 5 or more medications, that would be beyond standard. Using multiple medications from the same class also makes it difficult to know which medication is responsible for which symptom change. So for example, you may know about antipsychotic medications, one that are still marketed heavily. Abilify, you may see commercials as an antipsychotic medication. The use of 2 of those medications concomitantly or simultaneously would be difficult to know which medication was accounting for the symptom change you were seeing. Antipsychotics are the most costly medications that we use in the United States, which is another reason for concern. And antipsychotics, as you heard Mason and Giovanni talk about earlier, are those medications sometimes used in combination for treatment of ADHD, reactive attachment disorder, or PTSD, and those difficult to control behaviors. Given the complexity of the issue and the significant responsibilities on case managers, I think that the ability to exercise appropriate oversight was difficult. This was observed when medications were continued at above maximum doses for many months or years. There were also medication side effects that were well documented and medications prescribed, but at times the case managers or other representatives weren't aware of what side effects the children were experiencing. In reviewing these cases, we were able to make some substantial changes in the medication doses. We were able to make some changes in the number of medications, and several of these foster children have moved to less restrictive living environments, bringing them one step closer to permanency. I think as important as the changes we made in medication or medication-related side effects was the ability of state employees to feel more empowered to be advocates for the children. So we had a pretty aggressive educational curriculum that we delivered to DFACs and the case managers, and we also delivered that to some child attorneys, CASAs, foster families, anyone that could potentially be at a child psychiatric appointment advocating for the child. I'd be happy to answer any questions. Representative Aller mentioned earlier some recommendations about other states that have oversight systems. I'd be happy to comment on those if there are questions about that.
Well, I'll start it off with, when children were on medications for a long time, do you think that that was a failure of the system to have them reviewed by a child psychiatrist at a regular period of time, maybe because of moving between homes, or the foster parents not taking them?
I think it probably goes back to the time the medications were consented for. I think once a medication is started, it's difficult to assess whether that medication is still necessary. And so that at the time of consent, the person making that decision to start a medication is the physician making the recommendation, but the state as parent signing that it's an okay medication for my child to take since I'm responsible for that child. So I think part of it is what you suggested, that psychiatrists aren't involved along the way. But initially when the medications are started, who is the surrogate parent in the office with the physician consenting or not consenting to the medication or asking questions, and what clinical training do they have?
Okay, thank you. Representative Henson.
Thank you very much, and this is important. I know we do have a serious problem. I just had one or two questions here. It appears that through the bill, we're going to have people having independent clinical review teams, and I guess if you go to probably starting around line 72, if anyone's following this on the bill, the process for consulting with an independent clinical review team, and it includes a child psychiatrist before prescriptions filled with psychotropic medicine, but it's the independent clinical review team should not include the prescriber, which I assume is the doctor, and so forth. Isn't it difficult to have a review and a child or anyone when the doctor, in fact, has never seen the individual, seen them react, talked to them, or anything?
That certainly does make it difficult. In some of the cases I'm presenting to you, the combinations of medication that were continued for extended periods of time would be difficult to justify with any evidence. But certainly the ones that were more complicated, in-person evaluations were done.
But is there anywhere in this bill that it requires that face-to-face consultations are required?
I'm not aware that the bill at this point requires that.
Okay, is that a concern that we should be having?
I think that's a discretionary opinion of the person reviewing the file. I think DHS has made a step to bring a medical director on board, who I believe will be overseeing a lot of this. And I would believe that discretionarily you would make an opinion that, is this severe enough where I need to see the child in person, or can I make a recommendation?
And then my second one is, again, still in the same area, but the review, how long would it take? I mean, we have quite a few children in the system. We're talking of very few physicians reviewing this, and I assume it's going to be physicians, psychiatrists such as you who'd be doing the review, or?
My understanding is that there would be child psychiatrists reviewing the cases. A review of a new medication and whether or not to consent for that medication ranges from very simple to very complex. So for the kids that are already on 4 or 5 medications, I think the decision may be more complex about symptomatology. Consenting for an initial medication may be less difficult.
but time frame. I mean, if one person or two people are doing all of this, how many children are in the system and how long is the process? Is it going to be a long period of time before?
I can give
anything
you
can be done?
one of the models I'm most familiar with is Illinois, and they have about twice as many foster children as we have. They have the equivalent, they have 4 child psychiatrists working on that team. Not all of them are full-time. They have one full-time child psychiatrist that oversees that and others that are contracted. So I imagine this would take 1 to 2 child psychiatrists to do. They also have a team of psychiatrically trained nurses and a pretty good information technology system to keep the records on the children they consult on. They also have a pretty broad educational effort, which I think is an important part of any of this. If you're going to review things, educating providers, what you're reviewing and what you're looking for is important.
But I guess what I'm asking is if a prescriber wants to change the dosage of a medication,
Yes.
it's going to have to be approved. And is that going to take, 1 day, 2 weeks, or what kind of process are we looking at?
Discretionarily, I think that's something that I would allow DHS to design. Other states that do it would authorize informed consent for a range. So, for example, anywhere between 0.5 and 4 milligrams of this medication is authorized. Anything beyond 4 medications would have to receive additional consultation. But that you could adjust the dose from 0.5 to 1 to 2 to 3 with no additional request. And so that's typically how these review systems work.
And that informed consent is coming from the foster parents?
The informed consent comes from the state. The foster parent in some states is the designee for the state, but the state is responsible for that. So in states where they have a system that advises DFACS, or the equivalent of DFACS, DFACS receives the opinion, but DFACS is still the consenter and makes their independent decision.
Thank you.
I mean, I think the concern is children going, not the polymedicines, but maybe the ones seeing the psychiatrist for the first time. And I will say that Illinois is a state, it's one of the states that's on the verge of going bankrupt, and they have, I think that is because they have many more people employed than we do in the state of Georgia. I'm not being critical of the fact that they're going bankrupt. Well, I guess I could be. But the main thing is that I think they have more state employees than we do, and I think that the representative was trying to bring up the fact that in many of our departments we are understaffed, and there could be a huge delay is what she was trying to point out and what I'm trying to say compared to the other states. Any questions? Representative Harden.
Thank you, Madam Chair. And this is a great bill. It's something that needs to be looked at, and Representative Eiler, thank you for bringing it to our attention. But one thing I don't understand, it sounds like the way this moves through the system, and from the young men who testified earlier to their experiences, they may be in a rural setting one time, or they're moving around a good bit. Is there no central repository for the medical records? Do we not have electronic medical records for these children? Or are they just, when they move to a different home, they go to a different physician, a different pharmacy, and there's no communication as to this child's health record, medical record?
DFACS maintains health records in a centralized system. In this state it's called SHINES, and states are mandated to have an information system to keep that centralized. It's only as good as the information that's input. It's not automatic. And then related to medication, Medicaid is mandated federally to keep a record of all the medications filled, so they have a comprehensive record of all the medications, and that's accessible by providers.
All right, and is that accessed by the providers when the patient is brought to a new location?
That part is provider dependent, whether they reference the previous medications or not.
And I don't know, I don't want to get into making providers do something, but it appears to me that the state should require that a new provider review the record before making new recommendations on medications to be used. That's what happens in a lot of the polypharmacy that you're talking about. It's just one physician not aware of what the other did. Is there any current way to keep an electronic medical record or an ID card? Basically, I know there are some electronic cards that can be used that would follow the child so that new provider would have some access to what had gone on before.
The only thing I'm aware of that the provider can have access to reliably at this point is the medication history. And they can have that access. Access to the centralized record system for DFACS is probably less reliable at this point. Case managers change. Is the information accurate? Does it show up at the medical appointment? My experience is that it does not always, but I can review medications. The only thing I would add is when I reviewed these particular cases, what I would notice is that one medication that might have been tried back in 2007 was tried again in 2010, or even tried 3 times along a 6 or 8 year period.
And that's why I don't understand why we can't find some way of continuity in that record for the providers, because it puts a physician in a bad place, to try to provide not knowing the history. So, and now, am I wrong? Are not electronic medical records going to be mandated? And when is that date?
There are incentives in place already to have an electronic medical record. You can choose your own electronic medical record software, and they don't all communicate with one another. But there's already a mandate for the state to have a centralized record-keeping system for all the kids in foster care. And there is a section of that that has medical records. Providers at this point don't have access to what's maintained there.
All right. Do we know the time period before that state electronic medical record system will be in effect?
I do not.
And Representative Harding, I think one of the problems maybe, and why perhaps Dr. Wilson, that medicines have been used one time and used again, is the children that are on Medicaid could be the fact of, for a while, something will be approved by Medicaid, then they will decide to disapprove that medication, and something else will be what the state is using, and then they'll decide not to pay for that, and then they will decide to go back to paying for something else again. So I think we have a problem in what we allow and what we will pay for. I know it is a problem between the prison systems, because prisoners, and that would be juveniles too, are put on one thing, and if they're taken out of the prison system and go into community care, the community care may not have availability or Medicaid to pay for the same medicine. So we have this silo problem even with medications.
Right.
Representative Morgan.
Thank you, Madam Chair. This question is about, I have 2 questions about the bill, and you may be able to provide some professional expertise on one of the questions, but I wonder if the author can respond.
Yes, if it's brief.
Okay, sure. And first of all, thank you for doing this. Probably 15 years ago, I did an internship at DFACS, and I still remember going through all the files and seeing the number of kids who were on some kind of drug. And I remember then thinking what a huge issue this was, so thank you for doing something about it. My first question, when talking about reviewing the plan, it talks about, let me try to get to the
Thank you.
back here. When we're talking about the, I guess the review of what drugs are, if there are going to be changes, it talks about a guardian ad litem or someone who's appointed. Would a CASA also be an appropriate person there?
In my view, yes, it would be. But the issue is who gives consent. The committee's already touched. Who gives consent? I think in practical matters right now, it's the caseworker in the county that changes repeatedly. Where's the medical record kept, and who has access to it? Are the basic questions, and who gives the opportunity for the child to have what is medical standard requirement that he at least be informed, if not ask for consent. So the questions that the committee has asked are all very relevant to the difficult task of how you provide oversight. From my perspective, if a juvenile court judge wanted a CASA to take that role, and I believe they operate differently with different juvenile court judges' wishes, it would be very acceptable to me. The language of that particular part of the bill was to expand the opportunities for DFACS to decide who might participate in the issue of consent and overview.
But it would not preclude a CASA from serving
No,
that role?
ma'am. No, it would not.
Okay. My second question, on line 81, it's requiring documentation of the child's assent or objection. Why the age of 14 and why under 14? And you might have mentioned that. I apologize, I had another meeting. but just wanted to know the significance of the age of 14 and why under 14.
It's a very difficult, arbitrary issue about where you decide a child can drive, when you decide they can drink, and when you decide they have a right to decide which parent they're going to live with. In Georgia law, it's presumed that a 14-year-old has the opportunity to decide which parent he or she may live with. So we chose that 14-year-old as a standard in Georgia that we know about. But your opinion, whether it should be 12 or 16 or 17, is any age you choose to assign granting a right to a child that a child does not have would be a little bit of a personal preference.
Thank you. Representative Watson, you're last on the questions for Dr. Wilson.
Oh, thank you. It's nice to be last here. Thank you for thank you for what you're doing. Thank you, Representative Oliver. I just had a couple of questions. What are your thoughts on the 14 years old? Is that too old, too young?
I certainly don't think it's too young. We have children in our crisis unit from 14 to 17 years of age, and we expect them to know the names of their medications, the doses, and how often they take them. We should also expect that if they move to a new foster home, that they'd be able to tell their foster parents, I take this medicine because I'm depressed. So I don't think 14 is too young unless there are cognitive impairments. And at that point, they should have somebody else looking out for their medical care.
The utilization parameters that we're, I guess, putting into statute here, or would consider putting into statute, is, I will tell you, I practice medicine, internal medicine, and a lot of the parameters that come down from our national boards many times lag behind. Example with lipid treatment, it lagged behind for quite some time and did catch up. Is that an issue in the psychiatric field, or many medicines, from my recollection, are not studied in children and in young folks. It doesn't mean that it's not indicated. I'm sure as a psychiatrist, you prescribe many medicines that are not indicated by the FDA. Your thoughts on that?
And just so I understand your question, whether or not clear.
I guess sort of several. Maybe I didn't articulate that very well. We're putting into statute something that will be required by physicians. That's going to be or people who write prescriptions. Putting into law something that will have to be updated and many times lags behind current medical practice. Lags behind the literature that you read, whether your psychiatric journals and so forth. Whether that's 6 months or a year or two or several years. I guess that's the first question.
I think the most important part then related to that of the bill is that it is driven clinically, and it's driven by a team, often either of clinically trained therapists, but usually psychiatrically trained nurses and child psychiatrists, so that when you're talking about getting consent, it's not strictly done by parameters, but that there are clinical professionals running that consultation team.
That sort of brings up the next issue is that, in Georgia, maybe not in Atlanta, but certainly in South Georgia, smaller towns, many times the physicians or PAs that are treating these patients in foster care are limited. There are just not very many out there. A little bit of my concern is that is this going to reassure them in their treatment? Or is this going to make it more cumbersome for their treatment? It's a little bit of a mixed bag there.
I think what you're getting, I think it's tough to predict the future and I think that's a concern any of us would have. I would have the same concern that if I'm going to prescribe a medication, would this restrict the time to when the child could obtain that medication? On an outpatient basis, most of the consultation systems that are in place would turn that around within a business day, within 24 hours, but it's an added step with the intent to avoid inappropriate use of medication.
It is, I'm sorry. We have the cold cases, and it sounds like we're doing a better job in the state of Georgia, and that's certainly a good thing. My concern, though, is sort of the big picture. Is that in places where there are not very many physicians or PAs or clinical nurses and so forth to take care of these patients, is that going to discourage them from seeing foster foster patients or children in the foster program?
I would certainly hope not. I think with any oversight program, the educational piece is as important as anything, in that they actually get more access to education about the appropriate use, so they may feel more comfortable prescribing, knowing that when it gets to the consultation team, most of what they're prescribing would be approved anyway.
If fragmentation is an issue in relating to what Representative Harden brought up, and that's obviously sounds like a major portion, along with the education that y'all have done. Is that not a better way of handling this with fragmentation and education and removing that? I mean, if DFACS actually has the medical records in Atlanta, I mean, goodness gracious, you know, why doesn't the physician have it?
The responsibility for DFACS that I understand is for them to have a centralized system to maintain the medical records. It would be incumbent on who accompanies the child to the visit, and it's not always the case manager accompanying the child to the visit. I've experienced the same where the records don't accompany the child, but I think that's an area of opportunity for DHS.
Maybe we should legislate that.
Okay, Representative Watson, I think you've touched on the fact that this is not just about medications. This is about a system that has problems in several areas that lead to the symptom that we're worried about now. Thank you, Dr. Wilson.
Thank you.
Okay, Representative Pack and Representative Kidd, are your questions to Representative Aller to the point where I can go ahead and let people present? Or do they need to be asked? This is a hearing. You're out of, I'm not taking a motion. Representative Pack, do you need to ask it now? Okay, Representative Oliver.
Thank you, Representative Oliver. Quick question on the I feel like I'm over-lawyering this, but if you look at the definition in lines 31 to 36, as I read that, we define child and children as someone who's under the age of 18 who's in the custody of the Department of Human Services. It includes another subset of individuals who are in the custody of the Department of Human Services and another state department, but not the Department of Juvenile Justice. Am I correct?
Yes, sir. We were trying to get at children who are in adoption placements. Okay. And we were trying to exclude Department of Juvenile Justice. But as somebody who's accused of over-lawyering a lot, I'm very sympathetic to that.
I appreciate that, because that was my question about what's the other state department. And secondly, if you look down to line 41, this talks about Department of Human Services shall establish regulations, which I think is the crux of the bill. But it seems to me as I read it, only applies to children in the custody of the Department of Human Services.
Yes, sir. And those are all foster care children. This is not to address the Medicaid population. It's only to address children in the foster care system. And some of the adoption children, again, there's some overlap there in multiple different homes. It is a rulemaking bill. It is a bill. The purpose of the bill is for DHS to adopt an oversight program and policy, which they're required to do. And one way to do it, and this bill sets out one way for it to do an oversight, is to do a rulemaking where there would be a public discussion and all physicians could come in and discuss it.
Okay. Right. So you don't have any problems with not capturing that subset group that we define in lines 31 to 36.
The juvenile justice crowd, as a decision made fairly early was not to include it in that. And the problem is that there's an overlapping group of children. There are both DFACS and juvenile justice, and that overlap, crossover children, I think would be included in the definition, but not the children that are just independently in juvenile justice. So, but it's the committee's. The Department of Juvenile Justice is not federally mandated to do an oversight program of pharmacy prescription drugs. And Department of Human Services, DFACS is for children in deprivation cases.
Thank you. Okay.
That concludes my witnesses, Madam Chairman, and if you look forward to hearing any other ideas on how oversight should work.
Well, we have other people that want to present. Dr. Peter Ash, you're first on this list. And can you tell us what you do, Dr. Ash, and your credentials?
My name is Peter Ash. I'm a child psychiatrist. I am currently the chief of child psychiatry at Emory University. I'm also the director of the Psychiatry and Law Service at Emory. In the past, I was president of the Georgia Council on Child and Adolescent Psychiatry. I'm the immediate past president of the American Psychiatry Academy on the Law, and I'm the president-elect of the Georgia Psychiatric Physicians Association. I very much appreciate the opportunity to address the committee, and I realize this is a complex problem with a lot of ins and outs, and I understand that there is a problem in some kids getting over-medicated. That's been clear for a long time, and the testimony you've heard today sort of outlined some of the more recent knowledge we've received about that. When I think about this kind of problem, it seems to me that there are two general sorts of approaches one can take. One is you can stop a doctor from practicing as they want before they do something. And the second is you can put in a process to review what's happened, and if what happened didn't work out very well, then you do something about it. And I think this bill, HB 23, has elements of both. First, let me say I think there is a need for review. Certainly there are these problem cases. They need to be reviewed. We need criteria by which to ascertain which cases need review, and once a problem is found, then obviously something needs to be done about it. And so I have some concern about what the pre-authorization process would be like, because I see that as an element of stopping a doctor from doing something he would otherwise do, as opposed to not slowing it down, have that happen, that may trigger a review based on the nature of what happens. Like if it's the fifth medication, that might automatically trigger a review that would then take place, and if it was later thought to be too much, that prescription could be reversed or stopped. However, my main point that I wanted to address the committee on today is something that hasn't been discussed too much so far, and that is the informed consent requirement for children over the age of 13. That's at line 69. As I read this bill, I'm not a lawyer, I take it to mean that it requires the informed consent of any child 14 years and up before a psychotropic medication can be prescribed to that child. I see this, frankly, as quite problematic for a number of reasons. First, it singles out psychotropic medications in adolescence as a kind of special category in the law. There really is no other medical treatment that requires special informed consent of a 14-year-old. So it's a kind of novelty. Second, it comes with what I see as sort of burdensome notifications. At line 101, every time you make a change, you have to let a whole list of people know. Now, I realize this could be addressed through some standard. You report it to one place, and then it automatically goes out to the guardian ad litem and all these other people. But if it means the doctor has to make 5 notifications, this is obviously a burdensome requirement. The second point about this is that these refusals would come up a lot. Adolescents are often quite oppositional. As teenagers, I think those of you who are parents of teenagers have had the experience that oppositionalism seems to go up, and at the times you're having an argument with them, it seems to go up more. And this is even amplified in the foster care population. As we've already heard, these kids are very challenging, their rates of oppositionalism are very high, and they are likely to refuse fairly frequently. Even if they don't refuse initially, they are likely to refuse at points down the road. I don't want to take the medicine today. I don't like it. And these medications can be very problematic if stopped abruptly. You can get discontinuation syndromes. All kinds of problems can come from that. And then what happens if the adolescent refuses? Well, the reality is we need to care for them nevertheless. It's not like an adult who, if they refuse and are living by themselves, they will, go where they go and do what they do. In this case, you've got either the foster care system or somebody who's now got to manage their behavior willy-nilly. This would also apply to inpatient facilities, and much of this is at state expense. And if you put a child or adolescent in an inpatient facility, are told by, in this case, the patient, you can't medicate them, your hand is really tied, and you can't do much, and they're going to stay. Their stay will be much longer, and what follows from that will be much more expensive. So, clearly there's some problems, but my view is around the objection issue that if an adolescent objects, this potentially could trigger some kind of review. That is, again, it shouldn't stop the process cold, but it might trigger a review, and then some group, I'm not sure how it would be constituted, would look at it and say, well, we think in this case we're going to continue, or no, we agree with the child, we're going to require it stop, something like that. So for those reasons, I find the informed consent provision very troublesome. I'm happy to take any questions if there are any.
Ash, questions for Dr. Ash? Dr. Watson.
Thank you. You know, I found that a little strikingly interesting about the age discrepancy between our two experts. It's very interesting. I will tell you my experience in practicing medicine, you know, from an adult health care. I do require my patients to know some drugs and know some dosages, but to require them to know several is, you know, as an adult is tough. As an adolescent, I think that would be much more challenging. It's interesting. So you're a professor now at Emory?
Yes.
And so was this your student that was just testifying?
Yes.
Interesting.
How long ago was he your student?
2 years.
Oh.
So you have you have a little gray hair here, I see. So you've been
and not much of it.
No, I hear you. So we can all identify or some of us can't. You're right. So you have I presume a practicing psychiatrist for quite some time.
Yes.
Still practicing, teaching, professor.
Yes. Yes.
Okay.
I started practicing. I started my residency in 1974.
Okay. All right. Well, we certainly do appreciate that, because I tell you, I was a little concerned about the 14-year-old, you know, thought process. Let me ask you the same question then, with the utilization parameters, putting that into statute and making that into a law. I have a little bit of a tough time if I'm a physician practicing internal medicine and the legislature's telling me that I'm going to have to prescribe or I'm going to have to fall into these parameters from a statewide standpoint. I don't have any problem from my composite state board of medical examiners or from my Society of Internal Medicine and American College of Physicians. I mean, I think that's very important, continuing medical education and doing that. But from the state telling us and always agreeing with that, I mean, my opinion on that is that generally, our societies have a tough time keeping up with current data, and to expect the state to do a better job than our societies, who are theoretically the experts in this, I find it a little troublesome.
I certainly agree with you, and I think it's particularly troublesome with kids around the issue of, for example, what's FDA approved and rules that relate to that, because about half the drugs, not just psychiatric drugs, all drugs that are prescribed to kids are not FDA approved because the drug companies have not bothered to, I shouldn't say they haven't bothered. They don't want to do the studies to get the approval because those studies are very expensive, and yet they have extensive use. And then those studies about what is an appropriate use or not, of course, are ongoing and change very quickly.
Cindy Dobbs.
Thank you, Madam Chairman. I'm delighted to see that this is being addressed in the legislature. But considering what you have just stated, I know that we're looking at the possibility of having not enough physicians to handle the number of people that need treating in Georgia in the future. With these additional regulations, do you think that's going to impact the number of psychiatrists that are willing to work with these children? And how much additional cost is it going to put on them?
Yes. Well, it depends, obviously, on what you ultimately come up with as the standards. I think that this is a challenging population. There aren't that many people, child psychiatrists, who work with it, particularly in rural areas. Some of this relates to Medicaid reimbursement rates. To the extent that it becomes more burdensome to treat this special population, you will find doctors, I think, moving out of it. I mean, I think a lot of child psychiatrists feel very committed to this population. We all recognize there's a huge unmet need there in terms of mental difficulties in this population. The question is how best to address it. But yes, to the extent that you have to go through pre-authorization processes and spend a lot of time and get prior approvals, that becomes burdensome, and that will tend to drive people out of working with this group.
Representative Kaiser. The last question for Dr. Ash.
Okay, thank you, Madam Chairwoman. This goes back to Dr. Watson's comments. I'm the mother of 13 and 14-year-old boys, so I am experiencing the challenges. And I don't know if Representative Oliver wants to speak to this as the author, or if you could talk a little bit about what you would see when you go back to talking about an independent, fair process for kind of mitigating those differences, what you would envision that looking like if it is a 14-year-old saying, objecting to the drugs.
Well, I think that if you wanted to review, if you think, okay, the child should have someone hears the child if the child objects, if you believe that that's the way to go, then I think you could set up some process that the child could, and the child could be notified for each prescription, in fact, that they have this opportunity. And then you say you have to sort of make your case of why it's a bad thing and send it to some review board that could be constituted of, a child psychiatrist, a number of people, and they would look at it and see on the face of it, does this make sense or really not? And then there might be, if they think the child really shouldn't be getting it, some process that would trigger some process to really look at it.
Thank
I guess
you.
I'm wondering about the makeup of that group.
Yeah, frankly, as a child psychiatrist, I don't think I would be the best person to come up with the makeup. It'd be nice if a child psychiatrist was on it, obviously, because there's a question about appropriateness, but certainly other people could be as well.
Thank you, Dr. Ash.
Thank you.
Dr. Yolanda Graham.
Hi, everyone. Madam Chairwoman, thank you for allowing us to speak today, and members of the committee. I know it's getting late in the day, so I'll try not to speak for long, but I'm really glad that we have an opportunity to discuss this issue. As Dr. Peter Ash stated, members of the child psychiatry community really are proponents for having some type of oversight for children who are in foster care. I have worked with children, I'll qualify myself, I'm sorry. I am a faculty member at Emory and at Morehouse. I've been in the Atlanta area for 20 years. I'm the immediate past president of the Georgia Council on Child and Adolescent Psychiatry. I'm the current medical director at Devereaux, Georgia, which is a residential treatment facility in Cobb County. And I have been at Emory for years, and yes, I was also one of Dr. Wilson's supervisors, in case you're going to ask that. So we worked together closely for years. And as I said, there are great concerns that we have in the psychiatric community. As an outpatient provider, one of the most difficult challenges is having a patient or a child brought to your office with no history available. It's really difficult to make a decision and to administer an appropriate treatment plan. Oftentimes, there's a foster parent or a staff member at a group home bringing a client to the office that may have very little history. We may have a new caseworker who has very little knowledge of the child. So one of the greatest, I think, injustices is a lack of an oversight system in terms of an electronic medical record that providers would have access to. I also think that it leads to the problem of medications being tried again and again in a child. Certainly, when I ask children, why didn't this medication work? I don't know. Why did they change it? I don't know. But what dose was it prescribed at? I don't remember. And so it's very difficult to obtain records. So, I certainly, like I said, am a proponent of developing some type of oversight, but I think the issue is much larger than how medications are prescribed. I think the issue really does center around having appropriate information as a provider in order to be able to help children. I think Giovanni and Mason spoke very eloquently about some of the difficulty. I may see a client for one appointment because they moved to my county and my area, and they were at another provider 2 months prior, and they may change foster homes the next week and then are at another provider, and there's no continuity of care. And so being able to have a coordinated system with continuity of care, certainly if the medical record followed the child, that would be helpful. But as a parent, I'm able to make appropriate medical decisions for my children because I've been there their entire life. I know the entire history, and I'm able to provide that. Without having that provision, it's very difficult as a provider to provide adequate treatment. The other thing in terms of symptoms and medication management is that we know that children are still developing. Their brains are still developing. Children who don't respond to medication at one age may respond once they mature and their brains develop at a different age. And so being able to evaluate children along a developmental perspective is also important. I certainly would love to have access to Shine's record base if that's available and is accurate. As a provider, we don't have access to that. And so it would be up to the caseworker to be able to provide those records at the time that the child is being evaluated. I also have had the opportunity to collaborate with Dr. Wilson on several of the cold cases, and I have the unique pleasure of working in a residential facility where I think one of the greatest rewards for me is that we do get children that are in the cold case project who I received an 11-year-old who was on 12 different psychotropic medications. We had difficulty waking her up for 2 weeks in order to assess her. I think we can all agree that that's atrocious. What I can also tell you is that the majority of child psychiatry providers are not really in the business of seeing children over-medicate them. And so there are lots of difficulties in the system that actually lead to that. Like I said, I have the unique reward of being in a setting where we're structured and safe enough to be able to wean children off of their medications in a safe and controlled manner and look at other therapeutic interventions that might be helpful. And I'm happy to report, as Dr. Wilson reported in the Cold Case Project, many of these children actually do better on less medication than they do on more medication. The problem is, as an outpatient provider, when I was seeing children, if the foster parent is saying this child has to leave, they're destroying the house, they're harming the animals, they're doing these atrocious acts, please, you have to do something. You want to decrease the number of disruptions that this child has in the community, and you have very limited time to make a decision to do so with very little information. So we agree as child psychiatrists that there needs to be some oversight. One of the things, well, there's several things that I worry about in terms of unintended consequences. Representative Watson mentioned, the number of providers. We took a poll of, when I was president of the Georgia Council on Child Psychiatrists, of the number of child psychiatrists in Georgia who accept Medicaid clients, and it was less than 30%. And so we have already a paucity of child psychiatrists nationwide, especially in our state and rural areas. Less than 30% of those actually accept Medicaid. So the more burdensome we make the process, I think that will certainly, it has the potential to have an unintended impact on children. The other things that we've seen, certainly over the last year, as attention has been paid to this issue, is that it has impacted the way we practice medicine. For instance, there is now a prior authorization process for certain medications that are prescribed to children, and with that comes an administrative burden that also has caused providers to question whether or not it's actually worthwhile to continue to see that population. And because it limits the medications that you can prescribe, it has a potential unintended impact of children then taking medications that are older classes of medications that may have other side effects that we stopped using 30 years ago that now are being used in higher numbers because they don't have access to medications that have safer profiles in some areas, but certainly other areas where we think they need to be monitored. The other issue that I worry about in terms of oversight is the delay in informed consent. Certainly, it is difficult. The state has an obligation in terms of acting in local parentis for children, in their custody. At this point, I can tell you 2 examples of children that I've had in residential treatment. One that was severely depressed that I was seeking informed consent for, and we were told since the child was in defects custody, we had to wait for consent from the director of defects. We waited 3 months as this child became depressed, suicidal, and languished in residential care, where our goal really is to get children back into the community. But as we talk about this issue of informed consent, children refusing medications or delays in consent, the other thing we look at is the risk of these children becoming institutionalized as they spend longer periods of time within institutional settings. I had an opportunity to review Representative Oliver's bill last year and this year, so I thank you for bringing it back, because we certainly think there needs to be some process. There are very few specific areas where I'll give comment on the bill itself. On line 26, One of the things it refers to is appropriate and properly managed mental health care. I would certainly argue that psychotropic medications should be a small component of the overall mental health treatment plan of children. I know that this bill is addressing medications. Certainly, I think at some area, at some level, the issue regarding the lack of therapeutic services, the lack of evidence-based services that are provided to these children in other settings needs to be addressed. Including in line 41 in establishing regulations for the use of psychotropic medication. I think that pertains to the issue that was just spoke of. Peter certainly handled the informed consent area. My other recommendation would be line 92 in terms of requiring records for children. In addition to current records, I think it's extremely important to include historical data, because I may get a child's current diagnoses and their current list of medications, which is helpful, but in order to really do an appropriate treatment plan, having historical data, including developmental data, would be extremely helpful in managing children. My other recommendation is at line 98, which also is in regards to a history of treatment. The recommendation is that all mental health and behavioral therapies, treatment services, and interventions be provided as a list, and again, I would recommend that include previous treatments as well. So I thank Representative Oliver for the opportunity to collaborate, and certainly the Barton Clinic and others. We have a vested interest as child psychiatrists who treat children who are in foster care. None of us are getting rich doing it. None of us are on the boards of the pharmaceutical companies. The people who see these children are people who have a passion for helping children in our state, and these children certainly are our most vulnerable population. And so I thank the committee for your time.
Dr. Ram, and before I ask the question, I want to thank the committee for hanging with us. I told you this was going to be a real important issue, and I appreciate you hanging and staying all the time. The one thing what I hear you saying about that psychotropic drugs are important, what I heard you say, I think, is that we do not provide other services such as counseling on a regular basis and that kind of intervention that a private child might get, that the state for these foster children, we do not provide those type of services as needed usually.
Right, those services are provided, but what you see is a lack of continuity of care, as you see within this area.
And was the other thing, we always, I think, as legislators have a little running issue about which drugs are prescribed. So what you're saying is that because drugs often become cheaper and there are generic drugs for them, that the state might choose to use a really old drug when things that have less side effects and are more effective, they might not use because they're newer drugs and cost more.
Certainly, I think the biggest issue that we see on the front page is, the issue surrounding atypical antipsychotic medications and the risk of metabolic syndrome and weight gain. We certainly are, I think, vigilant about that within the profession. What we don't see are the side effects associated with the other classes of medication that are alternatives to these that can actually be used successfully in an overdose attempt, that can actually kill a child. And so I do think that there needs to be parity across the board that's independent of cost.
Okay. Representative Himpson, can you do one? I think we have one more presenter or something. I hope. Is our new director that is with DSH, is she here? Good. Hold on. Save the best for last, maybe? Or are you Dr. Hippolyte?
Anija.
Pardon?
Anija.
Anija, okay. Okay.
Very much. Please tell me if I'm wrong. Basically, you're in favor of the intent of the bill.
Correct.
But not the way that it is currently written?
I think the intent of the bill is to enforce regulation by the Department of Human Services, and I think that needs to happen. There needs to be a regulatory process. I think the way that process is developed is important, and I think that points that may serve as barriers to treatment certainly need to be addressed, and that would include the informed consent process, the issue regarding the Oversight Review Committee and how often that's done, and what is the parameter to establish that. And certainly there's been a group of child psychiatrists that we've been working in collaboration to look at appropriate prescribing parameters.
Just a quick follow-up. Do you have suggestions, specific suggestions for this bill that, in your opinion, would make it a better bill?
Right, and I hopefully stated those earlier, and I'd be happy to share those with the committee, but I think including the language of historical information in addition to current information on treatment, I have concerns as well about the informed consent requirement from children at age 14. I think that raises a great issue. The other issue I would argue is one of obtaining written informed consent. We typically, one of the difficulties is that if a foster parent brings a child for an evaluation, they are not allowed to provide consent, even if you give them the informed elements of consent. And so it still takes some time to wait to get the legal guardian in order to provide consent. And so the more cumbersome that process becomes, it results in a delay in treatment. So those would be the specific components of the bill.
Okay. Thank you, Dr. Graham.
Yeah.
I'm sure she would, that people that are out there practicing now would be willing to help us with more specific things if the bill moves on. Thank you for that question. Thank you very much for coming. Dr. Anisha, welcome to state government. Thank you very much and for sitting through all of this. But I wanted you to hear it all, so we're glad to have you with us and in your new job. And if you will introduce yourself and tell us about your background and what your new job is, and then your comments on the bill, not necessarily the bill specific, but how we go forward and what the department is doing right at the moment.
Okay. Good afternoon, Madam Chair and members of the committee. I thank you all for giving me this opportunity to come and speak to you regarding the issue of psychotropic medications. I am Alka Aneja, a board-certified child and adolescent psychiatrist, and I'm currently the medical director for Department of Human Services, and I've been in this position only 3 weeks. So when the questions come, I guess I'll go with the flow. To let you know a little bit briefly about my background, I did my psychiatry residency training and then went on to pursue child and adolescent psychiatry fellowship training at Johns Hopkins University School of Medicine. And I also worked as assistant professor at Johns Hopkins University, where I was involved in research in the area of autism and have published in that area, as well as supervised residence. So I was more extensively involved in treating and diagnosing kids with autism, developmental disorders, and other psychiatric illnesses. As per my role with DHS, I am including in my role, or am I supposed to be including in my role, providing medical direction, clinical oversight, as well as helping with the education of the staff for the Division of Aging as well as Division of Family and Children's Services. Also, I am specifically for Division of Family and Children's Services, I will be looking into reviewing cases for child neglect as well as implementing best practices, helping them develop some policies, and while collaborating with other departments like Department of Behavioral Health and Developmental Disabilities and Department of Community Health. So in terms of my priority at DHS, I will be addressing DHS's role in the well-being of children, and specifically the Commissioner has asked me to look into the issue of the use of psychotropic medications among foster care children. And I am going to be using multiple sources of information, and one of the first things I'm doing is setting up a panel of experts so that I can have the information that would be helpful to go forward in the usage of psychotropic medications. Thank you.
It sounds like that we've, as you probably heard me say before, it's a department that needs a lot of work, and they have set large challenges ahead for you. Questions for Dr. Anicia? We have none. So we'll look forward to talking to you in the future. So thank you very much and welcome again. Is there anybody else that I missed or that would like to come forward and speak on this issue? Okay. And you are? Okay. Mrs. Hippolyte.
I'm not a doctor. I'm just a mother, and that is the best job. As a mother of a 15-year-old, I moved here to Georgia in 2007, bought a house, evicted a year and a half later after a marshal evicted me with my child, and I'm in the street. If I'm standing here, it's by the grace of God. I went from shelter to shelter, living in my car because I want to protect my daughter. No jobs, but I'm still standing. And my job is to protect the only child that I gave birth to at 34 years old. Could not find a job. I live in shelters, and I see the pain of mothers and children that are leaving because they are scared of defects gonna come take their child away. When the mothers did something wrong, defects is the first name they call and said, if you don't behave, we're gonna call defects. So these mothers, they are dying. They need help because they want to take their children. After I was evicted by the police after 3 months because I could not find a job, I was back in the street. My only house was my car. First I was in DeKalb County. They put me in a mental institution because nobody should live in a car with a child. But at that time, I trust God. And my child was in Stevenson Middle School. She was a high achiever. We sat in the car and do homework together. I would do anything to protect my child from negative elements. When I was evicted again in Fulton County, I didn't have a choice but to live back in the car. And I investigated and I found out about homeless. I have the right to leave my child in the only stable place, the McKinley Act. So I made an arrangement and she was still going to school. DFACS come in 3 days and said to me, we're going to help you. They come with the word of God. They deceive me. We're going to help you. In 3 days, the due process was wrong. My child is in DFACS at this time right now. The need is not for drugs. There's nothing wrong with these children. These drugs are destroying them. When that chemical gets in your body, like Giovanni said, they drive you crazy. My daughter is actually right now in DFACS custody. I lost my rights as a mother. Who's standing? Who's standing for these children? I met children that are in the street, homeless. They are products of child foster. When you call somebody because they have a certificate to be a mother, a foster care mother, they have a better apartment, a better house. But nobody knows what's going on to their mind. Nobody knows what happened to our children when they left foster care. They become prostitute because they become sexually abused. Who's looking for God's children? Who's looking? I trust God with my child, and because of her I can be standing in here and represent this group. I'm not against medicine, but these are not the needs. At that time, when my child was taken away, the need was to put the mother and the child together. But guess what they did? They tried to root me into the system. Psychological evaluation? How can I have psychological evaluation and my child, all I need is a place to live? Give me a chance. I don't know if I'm talking regarding the bill, but I'm here. And our children are dying behind closed door in the foster care.
Thank you very much
for
coming. We know we have problems. That's one of the reasons that Representative Oliver has brought this bill. sometimes the magnitude of our problems are overwhelming, but this goes out over the web, and there are people here in all these areas, and they have heard your story, and thank you very much for coming.
Thank you.
Thank you. Okay, are there any other questions for Representative Oliver? Representative Oliver, thank you for bringing this issue. We will continue to talk, and I hope you will continue to talk to people that have voiced their concerns about this bill, and any members that want to talk to you about it further. Thank you very much.
Thank you for the generosity of your time.
Thank you, and thank you to everybody that testified, and this meeting is adjourned. Thank you again to my members. You are the best. Thank you.